Yeah, for me, it's a great pleasure to be here because honestly, part of my heart is in Padua. And so I'm looking forward to come back, from Switzerland. If we come to Veneto, we have to quarantine because Veneto is really a red region. So I'm really looking forward to be able to come back. And then we can, of course, meet all together. So without further ado, just thank you, Christina, for the biographical sketch. I would just like to add a few notes because there are many young colleagues listening to us. So yeah, what I would like to tell you is I did my clinical board certification, and then thanks to the inspiration also of Professor Tiene, the PhD, and I really thought this was ideal because I wanted to investigate cardiovascular disease from the clinical point of view and from the experimental side. And during this past year, I follow both track, and now I have my own research group at the University Hospital in Zurich. So keep up with the motivation, don't leave your aspiration, and at the end you will reach your goals. So this is my take-home message for all the young colleagues listening to us. So today we will look at the role of endothelial function in the pathophysiology of cardiovascular disease. I will talk about how COVID-19 affects the endothelium. And I will just say a few words about a multicentric study that looks at long-term consequences of COVID affecting vessels. So, as you see, we have the 40 years anniversary of this seminal paper. This paper was published in Nature in 1980, and it was the first time that they recognized the crucial role of endothelial cells in controlling vasodilation. The hot question at that time was exactly why vessels are able to dilate, which is the tissue, which are the cells controlling that. And what Robert Furgot demonstrated is that vasodilation was possible only if in the vessel there was an intact endothelium. And then many other scientists contributed to show that the endothelium is able to produce nitric oxide, an unstable free radical gas that is highly reactive and is lipid soluble. So the endothelium that was known to exist till 1980 now became center of attention. This is a single cell layer that lines the lumen of all vessels, so it can reach an area that is more than 7,000 square meters, so imagine around 6 tennis courts. And it's, of course, in a strategical position because it controls the transport between the bloodstream and every tissue and organ that are close adjacent to vessels. So control delivery of nutrients, oxygen, and removal of catabolites from tissues. This was really a fundamental discovery, and it really was the beginning of vascular biology. These three gentlemen here for this discovery became the Nobel Prize in 1998. And as the motivation says, for their discoveries concerning nitric oxide as a signaling molecule in the cardiovascular system. What is really interesting is that Alfred Nobel himself was very much close to nitric oxide, but he didn't know that. So as you know, he became rich because he was producing dynamite in his company in Stockholm. And nitroglycerin was used at the time of Alfred Nobel against angina, against thorax pain. And Alfred Nobel himself was suffering of angina, but he always refused to take nitroglycerin because what he also knew very well, working in his company, is that nitroglycerin was able to provoke very, very strong headache. And that's why he never wanted to assume it. What he didn't know, and it took hundreds years to find out, is that nitroglycerin is able to relieve chest pain and is so reactive because it releases nitric oxide. So the three gentlemen got the Nobel Prize, but of course, in these 40 years, there have been many scientists that contributed to know and characterize nitric oxide and all its pleiotropic effect. What we now know is that nitric oxide is able to maintain vasodilation, and we also then recognize other vasoactive mediators. An healthy endothelium is quiescent. It has tight junctions so that the transfer from blood to subendothelial space is tightly controlled. There is an intact glycocalyx on the surface so that we can have a laminar flow without aggregation of platelets or thrombotic formation. We also always have nitric oxide itself actually as an anti-inflammatory phenotype. So Professor Paul Van Hout is one of the many scientists who contributed to all the knowledge we have nowadays. Here you see a picture when he was at the Mayo Clinic. So yeah, he unfortunately prematurely passed away short time ago, and he's really one that didn't got the Nobel Prize, but really contributed a lot. I had the honor to know him because he was coming to the University of Zurich to give us advice. So I have the honor to be one of his mentees. And Tom Luscher was a student of Paul Van Hout. You know him because he's the past editor of the European Heart Journal. He also taught me a lot. So after 40 years of research on endothelium, we, a working group on atherosclerosis and vascular biology of the European Society of Cardiology, thought it was really the time to collect and summarize, make the point of the state-of-the-art knowledge on endothelial function in cardiovascular disease. And this is a position paper that we just published at the beginning of this year, and we worked together with the other working group, as you see here, and I really recommend to colleagues who want to have really an overview on the topic to refer to this reference. We there defined what endothelial function is, what characterizes a healthy endothelium and a dysfunctional endothelium. So as we said just a few slides ago, this is how the healthy endothelium looks like, and this is what happens once there are insults. Let's think, for instance, about an infectious disease, because now it's really the hot topic. So once there is some noxa, some insult, the endothelium will become activated. So this means that the glycocalyx on the surface will be degraded, and therefore there will be like the expression of molecules that trap monocytes. So there is an active recruitment of immune cells. Immune cells will go into the subendothelial space because the junction will not be tight anymore. So massive immune infiltration and the pro-inflammatory phenotype, because the endothelium is able to secrete cytokine. We will have also decreased nitric oxide production, and so a pro-vasoconstrictory state, death of endothelial cells. If this insult is resolved, then we can restore the normal endothelial function. But imagine if you have a lifelong damage, like if you are a smoker, if you have an inflammatory disease, as we saw, for instance, in the clinical case, if you have dyslipidemia, diabetes, obesity, these insults will really go on for months and years. And at the end, we will have fibrosis, deposition of lipids and necrotic immune cells in the subendothelial space, plaque formation, atherosclerotic disease till the clinical events. And this justified still high impact of cardiovascular disease nowadays, even it remains the first case of death. So how do we measure endothelial function? This is also a section that you can find this position paper. Well, the vasodilation is the most commonly accepted surrogate measure. So it's based on the assumption that a healthy endothelium is able to produce nitric oxide and therefore to cause vasodilation. There are invasive methods. So in the 1980s, after the discovery of enol, they start with a catheter injecting nitroglycerin in the coronary arteries, and you can see vasodilation, and this is done nowadays. But of course, this is a very invasive method, and so, for instance, for research studies, not really easy to apply, especially to monitor, for instance, therapeutic intervention. So the non-invasive flow-mediated dilation, FMD, has become the most widely used technique to evaluate endothelial function. It has been introduced in 1992 by Sellermeyer, that was working in the group of John Deanfield at the University College London. And this is the first paper they publish, where they look at flow-mediated dilation in young children with familiar hypercholesterolemia. And what they observe is that already at young age, in this specific disease, there is an impairment of vasorelaxation. So what do we do with FMD? Is it possible to visualize, for instance, large artery, here the brachial artery, with an ultrasound probe, and to take the diameter at baseline. After that, with the tear cuff, we will provoke an obstruction of the blood flow. We will inflate for 5 minutes at suprasystolic pressure the tail cuff, and after 5 minutes we will release it. So we will have a reactive hyperemia and shear stress on the brachial artery. If the endothelium is healthy, shear stress is able to induce the production of nitric oxide. And so with the ultrasound probe, we will measure an increased diameter of the same artery. And the ratio will be the flow-mediated dilation. So these methods became very popular, but as usual, devil is in detail, because it looks easy, but I don't know if some of you have experience in doing that. It's extremely difficult. Think about keeping, after the hyperemia, the probe at the same identical position. So for this reason, in 2019, in the European Heart Journal, there was this position paper with recommendation from experts. So FMD seems to be easy, but in reality, it's a very challenging technique. It necessitates extensive training, standardization of protocol in order to be able to have reliable results. When it's done properly, then it's a good technique because it is associated with cardiovascular disease prognosis, as you can see here in different meta-analyses. So now about the endothelial dysfunction in COVID-19. We know in this audience that the SARS-CoV-2 enter with the respiratory tract and infect the pneumocyte at the beginning. It enters cells via the membrane-bound angiotensin-converting enzyme 2. And then we know that in cases that progress to severe manifestation, we have a strong immune reaction. This leads to diffuse edema, low gas exchange. Eventually, we will have an acute respiratory distress syndrome. And then systemic inflammation, the cytokine storm, sepsis, and this will lead to multi-organ failure and, unfortunately, to death. So it has been really clear from the beginning last year that cardiovascular manifestations are indeed very common. And so acute coronary syndrome, myocarditis, heart failure, arrhythmias, these are, for instance, contribution from Padova, or this is a colleague that works in Dolo that is also COVID centered, and there are many, many others. So the question has immediately start to arise, what about the endothelium? Because the endothelium is the gate to the cardiovascular system. And in the endothelial cells, there are a lot of ACE2 receptors. They are really abundantly expressed. And indeed, in May last year, colleagues from the pathology of my university hospital in Zurich were able for the first time to show that there is a direct viral infection of endothelial cells in different organs. This is, for instance, a kidney. They could also show it in the small intestine, in the lungs. This is then another publication in the New England Journal where another group show this is an endothelial cells, these are the red cells, and they could show this viral present inside the cells. So there is an endothelitis, how they call it. So after this first paper, there was increasing evidence about the role of the endothelium in the COVID-19 infection. And so we, with the working group of atherosclerosis and vascular biology, again thought, let's collect and let's put order in all these evidence and to communicate which are the key points about the involvement of the endothelium during the infection. And so important is that we remember the endothelium is a target for the virus because, as we said, there are a lot of ACE2 receptors, and so endothelial cells can be heavily damaged by viral infection. But what is really important is that the endothelium will also act as a factor of the COVID virus, because as soon as endothelial cells will die, they will just activate themselves. They will contribute to recruit immune cells. They will contribute to produce cytokine, and so they will really actively support the immune-mediated disease. Moreover, as we discussed just a short while ago, if the endothelial surface is activated, it will promote platelet activation, thrombus formation, if endothelial cells die, we will have the subendothelial space that will be exposed to the blood. And of course, this is this extremely potent trigger for prothrombotic phenomenon. And last but not least, if the endothelium is not producing nitric oxide anymore, there will be a generalized vasoconstriction. And if we have an underlying, for instance, atherosclerotic disease, this can be really a trigger for ischemia. So we know that there are cases of COVID in healthy subjects, but we also know that more frequently patients with comorbidities and like obesity, diabetes, hypertension are those that have the worst outcome. And this is because endothelial cells of these patients are more vulnerable. They have an impaired endothelial functional reserve because the underlying disease is already creating a long-lasting injury. And so these are the patients that have higher risk of infection and complication. They are taking already drugs, and therefore there is a risk of drug-drug interaction. These are patients that maybe also have less access to the healthcare system, and they are those most fear of going to the hospital. And all these reasons contribute to their higher risk for COVID-related consequences. What can we do about therapy? Well, there are, of course, the first-line therapies. We all hope in the rapid diffusion of vaccination, because vaccine will be able to block viral replication and the aberrant immune response. What we can do instead to protect the endothelium is to try to use the drugs that are known to have a direct endothelial protective effect. And I'm meaning ACE inhibitor, angiotensin receptor blockers, and statins. These two classes of drugs are known to have pleiotropic beneficial effect on endothelial cells. So statins do not only cure high LDL, but they are also able to reduce reactive oxygen species formation. They reduce apoptosis. ACE inhibitor have an anti-inflammatory effect. So these are two class of drugs that we know are protecting the endothelium. And of course, keeping healthy lifestyle, because as we have heard, it's for sure not a very good idea to start smoking in the time of a possible infection. This will for sure make the life of your endothelium much difficult. And then, of course, we have those class of drugs that indirectly will help the endothelium to face the insult. And so cytokine inhibitors, corticosteroids, platelet inhibition, anticoagulants, these drugs will be, of course, helping, although they are not directly acting on the endothelium, but act against the consequence of the dysfunction of the endothelium. Just one point on ACE inhibitor, because there was a lot of rumors, a lot of emotion. So ACE2 have a pleiotropic effect. So on one side, with the feedback mechanism to the renin-angiotensin system, it promotes systemic vasodilation and has anti-inflammatory effect. So this is positive. On the other side, we have learned that it facilitates the SARS-CoV-2 entry into the cells, and this is negative. And of course, ACE inhibitor And angiotensin receptor blocker can increase ACE2 expression. So the question is, what is good and what is not good? Well, now we can really say that last year there were many observational studies, and now this year we start also seeing the first randomized clinical trial that show no association between the outpatient or in-hospital drug prescription and assumption and the risk of COVID-19 related admission or mortality in hospitals. So these are safe drugs. So in conclusion, RAS inhibitor statins are recommended in patients with COVID-19 and should be taken unless there are specific contraindications or intolerance, along with an optimal lifestyle measures. What is really important to keep under control, and we should really investigate, is the influence of sex and gender on the endothelial responses to the virus, because we see that there is a different reaction. It seems the female sex is a protective factor. And then the long-term cardiovascular effects after a patient recover from COVID-19, it's really to be kept under control, because as we know, patients still have sequela, so dyspnea, fatigue, and so the question is the endothelium affected? And my just a few slides are to make you aware of this study that is supported by the VASC-AgeNet. This is an European network that I'm part of, and this is the leading group based in Paris to look at the arterial stiffness and cardiovascular aging after COVID-19. So the hypothesis is, does COVID-19 induce early vascular aging? This we don't know, but has serious implications, because it means that patients with early vascular aging will load the health system a lot. So these are the patient population that will be recruited, patients with COVID infection and healthy subjects. And the study plans really long-term follow-up, up to 10 years, with a really precise vascular phenotyping. So at the moment, there are 52 participating centers all around the world, more than 500 recruited patients. So if some of you, Padova is a big hospital, so if you are interested, this is the contact, or just let me know, and we will know more about COVID. With this, I'm done, and I thank you all for your attention. I'm really happy to answer your question. And yeah, remember, we have open position for master, for PhD, for postdoc in cardiometabolic research. So if you wish to gift you an experience abroad, maybe contact us.